So that's our title today. It's the use of medications and clinical governance. It starts off with really regulation of medications, which came about after the thalidomide scandal in the 1950s. So various agencies eventually got together and formed the Medicines and Healthcare Regulatory Agency back in 2003. And they are responsible for licensing every medication that comes into the UK. So they're there to make sure that the benefits of a product outweigh its potential risks. And they're there to make sure that once a product is licensed, that it's used and formulated correctly. The MHRA you can register with, and the website is in the notes. They are also responsible for adverse incident reporting, which is the yellow card scheme, which I'm sure you've heard about before. And again, that website is in the lecture notes too. You can register with the MHRA and they'll send you out updates of medicine regulations and recalls. And it's worthwhile doing that just so that you're up to date with them. Once they regulate a medicine or give it a license, it's black triangled, as you're aware of, for so long. And it's black triangled if it's new or if it's a new formulation, such as IV paracetamol instead of oral paracetamol. And it's licensed, black triangled, if it's coming from abroad, if it's been made abroad. So you just need to be aware of that. Once it is licensed, it then can be adopted. And once it's licensed, you can prescribe a licensed medication. Any medical practitioner or non-medical practitioner can use that, as long as it's for the route that it was first licensed for. So you're still talking nationally. It can then be adopted by NICE in England and Wales. But in Scotland, we've got the Scottish Medical Consortium, which is responsible for taking on board the new licensed medication and passing information on the new licensed medication onto the local health boards, and any new formulations, it's got to be aware of that as well. So in Scotland we've got two. We've got sign given as our guidelines, our evidence-based guidelines, but we've also got the Scottish Medical Consortium. Now you can prescribe even if the SMC haven't approved the medication, because the medication will have been licensed. And for instance, in 2006, olopatadine finally became licensed by the SMC, but before that we were using it if there was a clinical best case scenario for that drug, if we could prove that that was the best drug for that particular patient, even although SMC hadn't approved it, we could go ahead and use it because it's still licensed, and then it becomes adopted. It's not good practice to use medications that haven't been adopted by NICE or SMC, but it can be done. And SMC, NICE and SIGN, they all approve the medications, and then it can get to local level. When it gets to local level, it's the Area Drugs and Therapeutics Committee who are in charge. And each PCC and health board has an Area Drug and Therapeutics Committee. And this is where we as a profession are just starting to get our toes into the water. This is a huge group with huge powers in each health board. And these are the guys that are responsible for introducing all new drugs and formulations into your local formulary. They're a multidisciplinary team. They're made up of people out with the health board so that they reduce the bias that there is when a new product is introduced. Once you qualify, if you want to start dialogues with your pharmacy people on your health board, then at some point it'll all come back to the Area Drugs and Therapeutics Committee for decisions. So their remit is to coordinate the introduction of new drugs, develop and maintain policies and procedures, and that's such as cytotoxic policies, secure handling of medicines, disposal of medicines. So anything that does affect the medicines, they'll have a policy on, and that's going to be for you to try and find out from your own health board what's affecting you. They implement the national guidelines from SMC and NICE, so the glaucoma guidelines will be implemented, and any other guidelines will be implemented firstly through the Area Drug and Therapeutics Committee in the Health Board. They coordinate the Trust Risk Register, and importantly they coordinate formulary control. That's a huge one. And approve non-formulary drugs user set up policies and how these are approved. So they make the policies. These guys are the policy makers. So if you, as an optometrist, want a particular drug on your local formulary, you have to go via these guys. And not only you, but GPs do, reps do, companies do. So these guys are really quite important. And that brings us to formulary. Now, a formulary is a small list of drugs, and they all have worked their way down from the MHRA. So they're all licensed. It's a small list of drugs, and really they're there so that the treatment can weigh up the benefits of cost and quality. You've got to weigh up cost and quality, and it's done through the formulary. And the 3 formularies I think you should be aware of are these 3. The BNF, which you're all aware of, it comes biannually, and it contains information on everything from the drug dose to side effects to contraindications to, importantly, interactions with other drugs. You have to be aware of those as well, and it gives dosage guidance for those with renal impairment, liver impairment. Work from the most up-to-date version of the BNF. It's clinically good practice to do so, and it's easy to do so because you don't have to have the paperback copy anymore. Although I'm sure that sometimes if you register with your health board as a non-medical prescriber, you automatically get a BNF sent to you and updated. But it's available online at bnf.org, and it's also available as a smartphone app, which the sad people among us have. So be aware of that. The other one is eMeds Info, which is available through the College of Optometrists, and it is an optometry formulary with systemic side effects and optometry interactions. Another good one to look at. But importantly, the one that's going to come down to is the local health board formulary. And in Glasgow, I've put the Glasgow formulary up there. In Glasgow, it's a 2-tier system. In Glasgow, you have a specialist formulary and a total formulary. And as specialists, we get to use a specialist formulary. Most other health boards, I think, just have the one formulary, making life a wee bit simple. Glasgow just has to be, again, that wee bit different. But you need to be aware of the formulary. You need to be aware of what you're prescribing. As Louise said, you might think you're writing just a prescription for dry eye, but oh man, can you upset people if you come off formulary? You upset the GPs, you upset the pharmacists, you upset the Area Drugs and Therapeutics Committee, and before you know it, they hate us. So, but we're new to it, and they're now starting to accept us onto it. But you need to be aware of what's there. Formularies are there for best practice. They're there to promote best practice. They were first introduced in secondary care to allow doctors to work from a small, safe list. And they're good in that they promote cost-effective practicing, and they give a framework against which targets can be audited. Now, that target might be the health board prescribing budget. So if you have a prescribing budget that you're not allowed to go over, the best way to control that is the formulary. Hence, they get upset when we go outside of it. Because budgets these days are big news, and we have to work with everybody, pharmacy, health board, everybody, not just as a profession now. The advantages of them are they allow the prescriber to become familiar with a small range of drugs, and it ensures continuity of practicing, because if you have a small formulary and you're away somewhere and a locum comes in, they've got the same formulary to work with, so there's continuity of care going on there. The disadvantages of a formulary are, to me, I have to say, it's the agreement of the formulary. You have 100 people sitting to agree a formulary, you'll get 100 opinions. And then you've got to maintain the formulary. You've got to be aware of what's being licensed newly and keep it up to date. So you have to spend an awful lot of time keeping that formulary up to date. And the range of drugs can be restricting. There can be, only 2 drugs available for dry eyes and a formulary of 40,000 drugs. So you have to be aware of what's on your formulary. And that brings you to you as a prescriber. And when you get down to be the prescriber, the medicines that you're using have come all the way down this system here to you. But in order for you to use them, then there are other rules and regulations that apply solely to you. First of all, you have to register as an IP prescriber with the GOC and your health board. There's a non-medical prescribing lead in every health board, and you register with them as well. And In the lecture, there's a pathway on how to obtain the prescription pad. With governance, it's more rules protecting the patient, because the patient is ultimately who we are there to serve. So practice is safe within competencies, and you have to keep a portfolio of your prescribing decisions. Now you do that for the GOC, and they can request that at any time. Some of us just keep a big word spreadsheet of our prescribing decisions, and the prescribing decision isn't just writing a prescription, it can be not writing a prescription and for what reason you're not, or referring because you don't want to prescribe. So as long as you have a log of your prescribing decisions, then the GOC can have a look at them whenever they require. You have to keep accurate patient records, and you have to add to a patient record within 48 hours if it's a medical record and not your own record. If you're seeing a patient, you have to add to that. You have to include other healthcare workers in your decision involving their patient. And that might not just be the GP, that might be a practice nurse, it might be social work. Anybody involving your patient that you've prescribed for should be informed so that their records are kept up to date, and just in case there are any interactions with other drugs that they may be on and that you're not aware of, because we're not quite yet that joined up system. You've got to keep up to date with best practice, and that's both local and national guidelines. You've got to ensure that your CPD is maintained, and that's your 36 general points in a 3-year cycle and your 18 therapeutic points in your 3-year cycle, and not just your points but your competencies as well. And you've got to be more aware of audit. Audit I put in there for 2 reasons. The GOC recommend that you do your own audits, and I think there's an audit kit in the GOC website. But it's easy if you're keeping a word spreadsheet of your prescribing decisions. It's easy to do your own audit. You know the conditions you're mostly prescribing for, you know which drugs you're mostly using, and so you can set up a dialogue with your local pharmacist to let them know what you're going to be using, and they'll stock it. But it's also good practice to see that you're not over-prescribing, or that what you're prescribing for isn't coming back to you not having been managed correctly. So it just gives you an indication of as a first-time prescriber of how to keep things in check. The other audit to be aware of is the PSD audit, which I think you'll hear more about later on, where all our prescribing habits in Scotland will be recorded by PSD, and they'll be able to produce your own prescribing habit record, and it'll be available to you as a prescriber profile, and it's available to you from your health board. And they will now be doing audits on our prescribing habits. We've not had one done because we're so new to it. We've only had the pads since last year. But that will be a method of governance. They'll show outliers, and it may well be that along with pharmacy and the optometric lead in your health board, there will be peer review so that they can tackle outliers, and it'll be used as an educational tool. The other thing you have to be aware of is safe and secure handling of medications. Most health boards have a policy for that. Some use sharp boxes for disposals of sharps, and some have yellow boxes for disposals of drugs and local pickups. I know different health boards, I think Grampian have that in place. We don't in Glasgow, and perhaps we may well do. And the safe and secure handling of prescription pads. A prescription, now that we've got the pads, can be written following a GOSI examination, but it's not a GOS arrangement, so you won't be paid for that. So you'll get paid for your eye examination, but not a separate fee for writing the prescription. We cannot currently refer to other IP optometrists, and you can prescribe on behalf of a colleague only after you've seen a patient, and repeat prescriptions are requested from the GP. Prescriptions themselves, this is the first glimpse we got of the GP10 was this. It has anti-fraud measures in the print of it. It is serially numbered, and again, as good practice, you should record the serial number as you're prescribing, and it lets you know if there have been any prescriptions missing or taken. The prescription should be written in black, legible ink, either printed or legible. It has to include the patient's name, address, and if possible, CAI number. If they're aged 12 or below, you have to put in their age in years and months. There is a prescriber number specific to you. You get your own prescriber number, and although you're registered with one health board, that number follows you all through Scotland and allows them to build up the profile on you. The practice name and address is there. I always put my telephone number in if it's not printed on it, so that the pharmacist, if they have any problems, can get back to you. This particular prescription here is the one that they printed off, and I really don't like because it says latanoprost eye drops and it doesn't specify which eye. Right? So specify which eye the drops are for. They may only be for one eye. That's highly likely in our profession, so make sure it's specified if it's right or left or both. And the Z off underneath so that the patient can't add anything to it. And other details to add are how the medicine should be taken, so that if it's a doxycycline, it can be taken with food. It should be taken with food. The doxycycline is an off-license use because it's not registered for using with blepharitis, but we can use off-license if we have clinical evidence as to say why. You shouldn't prescribe for family and friends, and you should really only prescribe for somebody that you've seen. And repeat prescriptions, as I said before, you request through the GP. Know the product you're prescribing. Know the formulation, the strength, the excipient and the cost. And that's all really helpful when it comes to formulary. I just put up a wee sample there, and all 4 products are carbomer gel, but they don't have the same excipient. The costs are similar, but if you've got a patient with a back allergy, then why not try carbomer gel non-proprietary when it's not got back as its excipient, and that saves you going on to the non-preserved at £5.42. So just be aware of what it is you're actually prescribing. It's easy to write a prescription for an artificial tear, but you really should know what the artificial tear is that you're giving. It might seem like it's just a small product, but it can have implications in what it's made up in. I put up 2 case records. I didn't know I was being recorded. I'm not sure I would have done it had I known. And I've only put them up just to show just some prescribing decisions, really. This patient had a routine eye examination, no family history, no previous ocular history. They had a decent myope, but the slit lamp examination was pretty obvious in it. There was iris transillumination and Krugenberg's spindle. IOPs were normal. So I'm thinking, okay, that's pigment dispersion syndrome, but let me just check out some other things. So I checked out that, and she's got a thin cornea, which I'm really not happy about. So she's got quite a thin cornea. Gonioscopy was grand. Visual fields were full, and those were the optic discs. The optic discs look slightly larger and asymmetric, but I think it was just my magnification and cutting and pasting. They're pretty similar in size. So they're about 0.5. Now, you might think still she's got a thinner cornea, she's myope, and she's got Krugenberg's, and there's a couple of risk factors in there. Am I happy to sit on that? So I look at the guidelines, and guidelines for NICE and guidelines for SIGN both say that pigment dispersion syndrome, if they're not showing any glaucomatous signs, can be monitored safely in the community. Now, I do glaucoma, that's what I do, and she's in my community. And I'm thinking, do I really want to sit on that? I don't have an OCT to hand, I wouldn't mind an OCT on that one, thank you very much. And I'm not so sure about her discs, although they're 0.5, I reckon there's some superior thinning on the right disc here, and I reckon we've got inferior thinning on the left one. If I got a wee pointer, I'd point, because I just think we've lost rim support down there. Right? So I've lost rim support there, and I'm sure when you see this clearer, there's rim support loss there. So I'm thinking, yeah, this is glaucomatous, but her pressures are normal, and she's no perimetry loss yet. Do I want to sit on that one? So as an IP prescriber, I make myself known to the patient that they are being treated by a non-medical prescriber. That's another thing you need to do. And see, in community, that's a doddle. In community, they love it. They come to you for years, and all of a sudden, you can give them their prescriptions, and they don't have to go and see another healthcare for their prescription. They love it in community. In the hospital setting, they like to be seen by a doctor, right? Because that's what they come to the hospital for. You can go to their optician to be seen by an optician, they don't need to come. But when they come into the hospital, I introduce myself as a non-medical prescribing as part of a shared care team. I'm just one of the team members, and they're happy enough with that. But this was in community, and I would like to have referred this lady because I wasn't happy with her disc appearance. But had I got her in the hospital, I'm not sure I'd have done anything. I'm not sure I'd have jumped in and treated as yet. I'd have had my OCT done, but I'm not quite sure we'd have jumped in and treated. Discussed it with the patient, discussed her options. The patient didn't want to be referred. She refused to be referred. She had other healthcare problems going on. So I noted in her records that she didn't want to be referred. And that's a prescribing decision. I've gone through the guidelines. I've discussed it with the patient. And that's what the patient has decided. And I've recorded that in the records. Right? So I've done what I need to do. She's coming back to me, obviously, because I won't sleep at night if she's out there without being looked at. She'll be back to me soon. And at one point, I'll get her up there. But at that particular point in time, that's not what she wanted. And so we have to abide by what the patient wants, not what we always think should happen to them. And we have to stick with the guidelines. You have to know those guidelines. If that guideline had said every pigment dispersion syndrome's got to be referred, then I would have referred her, but it doesn't. So we have to just be aware of all those subtleties out there. Case number 2, referred by me from a practice with suspicious discs, and the highest IOP was 19 millimetres. And I got it sent to the hospital for confirmation of normal tension glaucoma, because I had thought that, obviously. So they were started on travoprost by me in the hospital, right? And bearing in mind the highest IOP is 19, that's what she was initially referred in with, started on travoprost, and when she comes back to me into the hospital for a routine recall, their IOPs are 18 and 17, so they haven't really reduced on that travoprost. And the question there is, so what next? So my frustration is we're not quite yet a joined up prescribing profession. I can't get to write a prescription in my practice for the patient that I've referred in practice for the patient that I've prescribed for in hospital, because she's a hospital patient and she's under hospital care, and I don't have a computerised system to let them know that I've changed anything or added anything. And so therefore I have to then, and I'm really fortunate because my practice is in catchment of the hospital, I then go back into the hospital and say to the receptionists, see that wee woman there, going to get her an earlier appointment and going to, we'll do this and we'll do it. And I can do that, but that's not always possible. So my question there is, what next? Is really what's next for the profession as a step, as a big joined up step in IP. And that's really what, hopefully, a couple of years down the line, we'll be able to answer that as to where you are with IP now. And that's me, guys. Sorry to railroad you through all that, but thanks for persevering. Cheers.
So I'm just going to go through some of the sort of background to prescribing, the more sort of general policies that are in place. So we're going to start off with what the challenges are and why we're all probably, one of the reasons why we're all in this room. Basically, you're all looking around, you're all a bit younger than I am. So what's going to happen is in the next 20 years' time, there's going to be a massive increase in the number of over 75-year-olds. And that's going to bring with it a lot more eye disease. And there's going to be more treatments for that eye disease, and the GPs and the ophthalmologists are going to have more targets. In Scotland, access to community care is free, and that's been a great thing, I think. However, it's actually increased health inequalities in Scotland, unfortunately, which is common in healthcare. When you give a new healthcare treatment, the better off in the society take advantage of that treatment. So unfortunately, whilst we've had free eye care in Scotland, it's actually the better off that have taken advantage of it. So that's something that will need to be addressed. The second thing is that people are still turning up in secondary care that are actually registered blind at their first visit because of their glaucoma. So it still happens, and really that's a failure of the system. Something's not working in our systems if that's happening. It's not large numbers, but it does happen. And finally, in secondary care, people are still going blind because of appointment delays, so that really isn't good enough either. So the system isn't perfect. It's maybe getting better, but it certainly isn't perfect. This is basically the Scottish Government plan for the year 2020, and it's a bit confusingly titled for optometrists, because the minute we see 2020, of course we're thinking vision, but visual acuity, but they managed to complicate it even further by putting a colon in between 20 and 20 at the last meeting I was at. So it's pretty confusing stuff, but what they're referring to is not anything to do with vision. It's 2020, the aims of what the Scottish Government are for our health service. So, as I said, there's big challenges out there. We don't have the system in England where there's going to be clinically commissioned groups that are deciding on what's going to happen locally. Is anybody from England in this audience, actually? Oh, right, okay, there's about 5 or 6 of you. Right, so we don't have that in Scotland. However, funny enough, there's going to be enhanced primary care and shared care, just like there is in England. And funnily enough, there's going to be partnership with the public sector. There's going to be partnership with local businesses. I mean, I run an optometry practice. I'm a local business. I'm just an independent contractor. And there's also going to be partnership with the third sector, which is charities, like your Visually Impairment Society. Patient rights is at the basis of all of this as well. So you've all have heard of the Patient Rights Act probably, if you're in Scotland, because you should all have been filling in your complaints submissions every quarter. Are we all doing that? Yep, of course. Yes, say yes, because it's your terms of condition, so you should be doing it. But that came from the Patient Rights Act. The Patient Rights Act and Charter basically underlines what the rights and obligations that we have towards our patients. So access to healthcare is free, but the health board doesn't need to give you all the treatments that are available. You should be treated in a clean and safe environment with a knowledgeable practitioner who's also got clean hands as well. They get really specific in this. The information on treatments and potential side effects is something you have to give to each patient. And the patients have also got some responsibilities as well. It's not all just down to us. They are there to take some responsibility for their healthcare as well. Current primary eye care basically, obviously, is spread across a number of different professionals, and GPs are still the central point for healthcare and services. But 15% of people don't actually manage to get an appointment with their GP within 2 days. And that's actually a heat target. So this is something that I work in primary care services. So on the health board where I work, they actually monitor this on a regular basis, and this is something they actually monitor. So GPs are really meant to give people appointments within 2 days if the person needs it, and they're not always managing to do that. Obviously, a lot of patients are using out-of-hours service. We're not there from anything out of hours, so they use NHS 24, and they're also using A&E as well. We are also becoming more and more involved, and you're part of that. But patients, and as Maggie tells our patients that she's a non-medical prescriber, which I think is absolutely brilliant, because, and it's obviously what we should be doing, but it's important because a lot of people have no idea that we're actually prescribers, and they're delighted to find out that we are prescribers when they do. The amount of prescribing I do on a daily basis, I do about 15 prescriptions a month. I don't know, how many prescriptions do you do, Maggie?
In practice, probably roughly that. Yeah.
About roughly that, yeah. Okay, so we did a study in 2011, and we found out that this was right at the start of IP, that people were prescribing 18 prescriptions a month. It's quite manageable. It's manageable in your practice to be doing that level of prescribing. It's not going to totally disrupt your practice. So it's something that fits in quite well. But as it grows, well, we'll see where it goes as it grows. As Maggie said, following prescribing, this is a really important thing. The GP should be informed within 48 hours. I can't underline that enough. And actually, when I've been speaking to people that are already prescribing, I'm not sure it's actually been done. So you really need to remember to do this. Also, GPs are responsible, as I said, they're the central point. They're responsible for signing fit notes. So if your patient actually needs to be off work, then you should contact the GP and speak to the GP, and they can use your information to get a fit note for that patient. Glaucoma shared care. There's other types of shared care, of course, as well. Is there a lot of hospital optometrists in the room? Not many. Right, okay. Or are you just shy? Is that right? Okay. Well, obviously there's different types of shared care. There's the macula clinics, which are really growing and growing, but glaucoma shared care and ocular hypertension are obviously a big part of hospital practice. And because of the NICE guidelines, that care has to be consultant-led. So you can work in a clinic like Maggie does as an optometrist, and you can prescribe for glaucoma, but it has to be either consultant-led or you have to have the glaucoma qualification. Does anybody in the room have the glaucoma qualification? Nope. Right, okay, well, unless you're working in a hospital, you're not going to be able to prescribe for glaucoma, unless you've got some local arrangement, which I think maybe there's only Aberdeen that has that arrangement at the moment. Community care of glaucoma hasn't proven itself to be cost effective so far. So we haven't really shown yet that it's cheap enough for an optometrist in the community to actually provide this care. And actually, the NICE guidelines, which were produced in 2009, 2010, they've actually not shown to be cost effective either, compared with basically anybody who's got a pressure over 21 just gets treated for ocular hypertension. That's the Dutch model of treating ocular hypertension, is that they take anybody who's got a pressure over 21, they give them a prostaglandin analog or something similar, and they just get sent out into the community and they're monitored by optometrists. That's not the model we're following in the UK, but it is more cost effective than the models that we follow in the UK. So you never know what's going to happen in the future. It might move towards something like that. And the reason for that is there is a lack of capacity in the UK hospitalised services. Hospitalised services may not be feasible, but at the moment that's the current pathway, and that's the way it's going to stay for the time being, I think. So just coming finally on to some background to evidence-based prescribing. This is a complicated area, and it's often reported in the press in a way that really is there to create a bit of controversy, and it is. Sometimes this can be quite controversial. I think the Daily Express sort of lives off these sorts of headlines. But these headlines are based on the science out there that is beginning to show that people are often would do better to be sometimes treated with medications, even if they're not actually currently unwell. And also, some medications for people who are very unwell are not actually cost effective. And it can be really confusing and difficult for people to understand why that is. So for instance, these are two treatments that we can consider for ocular hypertension. Treatment 1 causes a 53% reduction in developing glaucoma. So that's quite good, isn't it? It sounds excellent. Treatment 2 really doesn't sound great, does it? You have to treat 19 people to prevent one person getting glaucoma. That sounds not very good as a treatment. And of course, you'll know that these are just different ways of actually presenting the same treatment. The first way is presenting it as a relative risk. So you're looking at the reduction in bad outcomes between a control and experimental group. So for instance, in the ocular hypertension treatment study, if you had a pressure over 24, you have a 9.5% risk of developing glaucoma if you're untreated. Whereas if you're not treated, if you're treated, you have a 4.4%. So your chance of getting glaucoma is reduced 53% in that study. However, that doesn't take into account the number of people who are left untreated who do not develop glaucoma. So for instance, if we actually look at the data in a different way, if we look at it in terms of the people, all the people in this study, most of the people who were untreated never developed glaucoma. Basically, what you've got to look at in these studies is essentially all of the study group. And essentially, that is captured in this statistic number needed to treat. So the same data, your 9.5% will develop glaucoma if they're untreated, and 4.4% will develop glaucoma anyway, even if they're treated. But most people don't develop glaucoma in the ocular hypertension study. So that doesn't mean to say that you don't treat these people, and some of these high number needed to treats are cost effective to treat. So just because it's 19 people have to be treated to prevent one individual developing glaucoma, doesn't mean to say you don't actually treat these individuals. But it has to be shown to be cost effective. And that's where the next bit of the discussion has to take place. So how do you know whether that's cost effective? Well, currently our budget in the UK is, in Scotland, is £1.1 billion a year. So it's a growing drugs budget. That's 10% of the NHS budget. And basically, we are going to be responsible for prescribing for our drugs. And as Maggie says, we have to be aware of what is a cost-effective prescribing habit. So we have to be very aware of what this is. I mean, if we use the local formulary, we're not going to go wrong, but we have to be using that, or being able to justify our reasons very carefully why we're not using that formulary. So, for instance, one of the ways we can justify medication is using cost minimization. And this is where basically you decide on a drug because it's cheaper than the other drugs, but you'd hope that it has the same effectivity. So, for instance, when Xalatan came off license, the Royal College of Ophthalmologists looked at the generic alternatives, which were produced by a number of different companies, and they decided that it was safe on the whole to prescribe latanoprost as a generic substitute for Xalatan. You won't always get away with it. There will be some patients where that's a little bit risky to do it, but on the whole, as a strategy, it's a reasonable thing to do. Another way of deciding cost effectiveness is to look at the cost per cure. And this is where you look at the effectiveness of the drug. Hypromellose is 26% effective if we look at Rose Bengal scores, the improvement in Rose Bengal. Whereas sodium hyaluronate is 42% effective. But the NHS cost for hypromellose is much lower than it is for sodium hyaluronate. So per pound spent, we get a much bigger improvement with hypromellose. So does that mean we should be using hypromellose for everybody? Well, no, it doesn't. But you can see why cheaper drugs sometimes are on the formulary, because there is more bang per buck, basically, for the health board. And they're looking at things from a population view, not particularly from a patient view. But that doesn't mean to say that that's always the right prescription to make, but it does explain why you'll see it at the top of your formulary. So using cost utility analysis is the way that researchers or manufacturers can justify more expensive drugs. And the way they justify it is, okay, it might be cheaper to prescribe hypromellose, but my drug will improve a patient's quality of life. And if it does that within a certain level, then it would be justifiable to prescribe. So if you look at a patient's judgment of their quality of life, and in your notes it explains how that's measured, and it isn't entirely uncontroversial. You have this concept called a QALY, and in the UK we're willing to spend up to £30,000 for a QALY. And treatment of some of the ocular hypertension patients actually falls into that level of cost. And so remember when I said about the number needed to treat was up at about 19 for those ocular hypertensive patients in that study. Well, close to that number needed to treat is actually acceptable. I think if you've got a risk of glaucoma of over 6% in 5 years, that is actually cost effective to treat, according to the latest studies. So basically, high number needed to treats actually are cost effective sometimes. What's out there once you've finished your qualification? Well, you've got the College of Optometrists Clinical Management Guidelines. If you're in the community, these are really what you should be using, and I look at them fairly regularly. I would imagine you do as well, Maggie? Yes. Yeah, I look at them all the time. I have them on my desktop and my computer, and I look at them regularly just to keep reminding myself what I'm meant to be doing sometimes. It's not always straightforward. They don't cover all the situations that you're going to come across as an IP, and there's been a lot of controversy about that lately. Amongst IPs, a lot of IPs feel a bit unsupported by the clinical management guidelines. But the College of Optometrists have actually said that those with the skills and expertise may work outside the guidelines, provided they can justify your actions. But you really need to be able to justify your actions. And I would have to say, as a prescriber, I use the College of Optometrists guidelines, and I rarely stray beyond them, even though they are quite restrictive, because I am a community optometrist. I've not got very much backup. I don't have anybody else I can run to and ask for a second opinion. So it is something I'm quite careful about. Hospital optometry is different. You are allowed to use local guidelines. And that was always the intention, was that clinical management guidelines were there for the community optometrist, but hospital optometrists can work slightly differently. And the justification for that is they're seeing different patients, different patient groups. They have got more backup, more clinical tests they can do in terms of swabs and otherwise. It's useful when you're out as a prescriber to get daily updates, just to keep reminding yourself of what's out there and what's happening. So I would suggest you register it's in NICE, I think, on the NICE website. You can register for regular updates, and I would suggest you do that. European Glaucoma Society, it's worth registering with them as well. You get their tips. College of Optometrist members can get an Athens account so that you can get the latest journal articles. I'm not saying that, I don't think prescribers on the whole spend their whole life looking at journal articles. That would just be a fantasy if we were doing that. But it's worthwhile sometimes, if you've got a difficult patient, to maybe go away and look at what the literature says, and you can get all the latest stuff from the Athens accounts. You can get all the latest journals from the Athens accounts. If you're stuck, you can also speak to your colleagues on a college forum. This forum's a bit more commonly used. The Ocular Scuro forum is more commonly used, but maybe post on both forums, because the College of Optometrists might reach different practitioners. And as Maggie said, you need to keep a regular, up-to-date audit of what patients you're seeing. And this is my spreadsheet that I use. It takes a second to type in the date, put in the NHS prescription pad number that you've prescribed, what you've prescribed and what you've prescribed for. It takes seconds to do, and it's a really helpful thing. I even list common prescriptions so that I just actually copy off that, because when you're in a rush and you're dealing with patients and you're in between patients, you want to be able to write it down quite quickly. So you want to have your sort of 0.1% olopatadine, and the size of the bottle that it comes in. It's quite a useful thing just to have that. And the GOC could ask for this at any time if you're an IP prescriber. So I thought I'd just finish off with some prescribing scenarios, just to give a flavour of what the sort of issues are when you become an IP prescriber. So this is actually a real prescribing case. It's not one of mine, it's one I had to deal with as an optometric advisor, but a contact lens patient presented with a red sore eye and corneal infiltrates to an optometrist. And the optometrist prescribed Exocin and Pred 40, and they justified that because they'd seen it on their IP placement at a hospital, and that's the way that they said that the hospital prescribed for that type of case. So basically, is this justifiable given that the College of Optometrists guidelines on contact lens keratitis don't really support that type of prescribing? I think it was quite a bad red eye and it was quite a lot of infiltrate, and I think they had seen that in hospital, and I think sometimes it is treated that way. I've certainly seen in the forums, it doesn't just happen in Tayside, it happens elsewhere. That is sometimes a prescribing that is done. It's a very dubious way of prescribing, obviously, because it could be that the person has fungal disease, or more likely it could be a herpes presentation as well. So there's a number of things going on. However, the optometrist wasn't totally off the mark in that sometimes people do prescribe like that for that type of case, and it might actually improve things. But there's a number of issues with prescribing like that, because of course you're using an antibiotic that is a very useful antibiotic, and you don't want to be wasting it on people that don't really need it. And if we start all prescribing Exocin in the community, then I think we'll soon be getting restrictions on our prescribing rights. So I would say there isn't really very much support at all for ever prescribing like that. How would you manage this in the community? If you have a teacher, viral conjunctivitis, that should be ringing alarm bells. Because of course you can't send her out the practice and tell her to go back to work. She's got to not go back to work. She's got to stop working for at least a couple of weeks, probably a couple of weeks. So you're going to have to write to the GP and ask for her to get a fit note so that she's not at work. Also, you're not going to prescribe for that, really. You're not going to prescribe steroid or anything for that, I wouldn't have thought. You haven't really got much justification for any sort of prescribing for that, apart from maybe if it's itchy, you could prescribe a mast cell stabilizer, but that's even pushing it. I would say you could prescribe artificial tears, but really there's not very much you can do at all for that one. Last one, cystoid macular edema. This is one that's happened to me repeatedly since I've qualified, is patients turn up with reduced acuity after a cataract operation. They've been discharged from the hospital. I mean, what are you going to do with these people? Because there's no clinical management guidelines. They are basically a surgical complication, so really they should be seen at the hospital again, but the hospitals are very, very busy, and even if they give them an appointment, they're not going to see them straight away. It's not an urgent appointment. I mean, by all means, if you can get an urgent appointment at the hospital department where they were operated upon, I think that's probably best practice. What I've ended up doing is usually writing to the local ophthalmologist, and they usually are quite happy for me to prescribe on my own responsibility, Acular and Pred 40. So that's generally what I do. And the patients are usually seen in the hospital about a month later or 2 months later, because at that point they might need an injection of steroid if things haven't cleared up, or they might need something else. So they might need some further advice from the hospital. So I prescribe for them, I write to the hospital, I tell them that I've prescribed, and they go to the hospital. Now, I'm not saying that's always the right way to do, but it's the way that works in my local area. So you have to work around all these different scenarios.